So, in summary, you can see that asthma and COPD are impactful diseases. Not only that it affects patients' health and outcomes, but also the healthcare system, and impactful because many of these patients continue to be uncontrolled and have recurrent exacerbations. However, how our look at both asthma and COPD has now changed in the year 2025. So, I was going to ask Frank, can you tell us, since you've researched COPD now for more than 20 years, how has it changed in a way our look at COPD? What are the main changes that you see, and how is that going to affect clinicians' approach to this disease?
Yeah, that's a great question, Nick. Thanks for asking it. And it's a pleasure always joining you with these activities. You're always very thoughtful in both these diseases. So the interesting thing is that I guess I would answer that question that 20, 25 years ago, understanding, we knew that there was variation in the disease, but even beginning to understand mechanisms behind it was very speculative. And the dream was that we would be able to identify clinical subtypes or phenotypes and mechanistic cellular molecular subtypes or endotypes that vary, and then to the next level that are eventually targetable. But we really didn't know what direction we would be going with that. And now, we already have a first Th2 high drug approved, and others hopefully on the way. And then, importantly, targeting other non Th2 high mechanisms as well with other biologics. And within that, there are probably many different sub-endotypes. Even of Th2, we're learning there's probably subtypes within that because Th2 is complex in and of itself, and one size even in that doesn't fit all. So I think now the reality is we are trying to implement the dream, and guaranteed, even in 10 years from now, we're not going to have it all solved. But we're at least in a direction that we're impacting human lives, decreasing hospitalizations, flare-ups, and importantly, the cost of medicine, because if things are too expensive, we're not going to be able to deliver care to the broad number of patients that really need to have better treatments for their COPD and asthma. So, I in that light, I think we do. Sometimes we need to simplify a little bit to understand. Sometimes we oversimplify, and I'm wondering, with regards to Th2 high mechanisms and eosinophilia, there's really been an important effort, and I think even within the FDA, to recognize that Th2 high COPD should not just be considered the same as asthma COPD overlap or Th2 high asthma. And I wonder, is there a mechanistic foundation that high eosinophils and Th2 mechanisms in asthma are different than COPD?
Yeah, no, I think you're right on asking this question, Frank. Obviously biomarkers are very important to help us, whether it's asthma or COPD, to identify the endotype that we're dealing with. Currently, there are only few biomarkers we use in asthma, blood eos, as you mentioned, sputum eos, and FeNO, and maybe IgE. In COPD, the role of EOS is rather new. For many years, we thought this is a disease that is characterized by neutrophilic inflammation, and actually EOS were less thought of. But now we know about 30% of patients, even if you rule out asthma, even if you rule out asthma COPD overlap, they do have peripheral eosinophils that are higher. Cutoff is 300 that we use. I think it's more of an artificial cutoff, but that's what we use based on trials. But the big question is the role of EOS in this type of COPD, type 2 COPD we call it, different than what it is in asthma? We know in asthma EOS play a major role in propagating the disease. It's not the only inflammatory cells. We know that we target eosinophils, whether targeted therapies targeting only eosinophils they do help in asthma, but do they do it in COPD? Right now, there are evolving studies looking at this. Um, People think that blood EOs are very good biomarkers in COPD, no question about it. The higher the EOs, the higher risk of exacerbation, the higher risk of readmission, the higher risk of decline in lung function. But at the same time, there may be the role is maybe different than in asthma in a way that there are only few studies now showing the population of eosinophils in COPD may be more resident rather than inflammatory eosinophils in asthma. I think we're going to have to see because right now, with only one targeted therapy approved in COPD and many others are in the pipeline, we'll see if targeting EOS is the right thing to do, only EOS, rather than targeting other pathways. I think but it's very important for our listeners to know that um, type 2 COPD is not asthma, it's a different phenotype. These patients are at risk of exacerbation. And again, they don't have to have any asthma features, even though shortness of breath and cough and wheezing can be present in these patients, but they don't necessarily have to have asthma to have type 2 COPD. It's a smaller group, 30%, but a very impactful group of COPD patients.
Yeah, that's great. And the emerging clinical trials really do show that it's a group that we could impact initially with inhaled steroids, but now with these biologic treatments to the next level.
Yeah, it's true. Like blood EOs right now in both asthma and COPD are prognostic biomarkers. They are predictive biomarkers. They predict response to inhaled steroids, like you mentioned, and maybe some targeted therapies. Um, whether the question is whether the role of these agents, these biomarkers, is the same as it is in asthma remains to be seen.
Great.